Hello friends, hello friends, hello friends, hello friends, hello friends, and welcome to the Union Labor Advisory Network. I'm Mike Fina. ULA's mission and vision is to support, educate, and promote union labor in our communities. There are great careers that you could have within the building trades as well as public sector unions. We're here to shed light on those opportunities, what they're doing, what these jobs are all about, and highlight them across the ULA's platform. Oh, we're going live now. All right, 5, 4, 3, 2, 1. Hello friends, and welcome to the Union Labor Advisory Network, where we work to support, educate, and promote union labor in our communities. Promote the people, partners who protect union workers and their families. Today's conversation is an important one because when it comes to health care, and especially prescription drugs, transparency, trust, and advocacy matter. We're joined today by RxBenefits, the labor team, Faik Gassi, who is the clinical pharmacist consultant, and Greg McAndrews, somebody I've known since I was growing up and it was about this tall, who is the strategic account executive with us today, just to talk about how they are helping health funds cut waste, protect care, and make sure every pharmacy dollar works harder for union members. So let's get started. Again, Greg, it's crazy that we're back here today. Going full circle from like growing up in Bay Ridge, Brooklyn. Our careers have always worked and for the many cases, probably for the past 20 plus years, we've been working in the union labor space.
Exactly.
Right?
Exactly.
I mean, it's crazy. And I know, Faik, you're coming in from Detroit, today. So thank you for, making the trip.
Absolutely. I'm happy to be here.
Yep. And we're going to learn a little bit more about you as well. But for Greg, give us a little overview of your career within the union labor space and how you got started and how you got to be with RxBenefits.
Well, as you said, I'm from Bay Ridge, Brooklyn. Been in the city my whole life. And way back in 98, I started working on the healthcare side, HIP Health Plan. And obviously that was a union-driven organization, mostly worked with labor. I started out in sales, quickly got into account management. Became the director of account management over there, overseeing labor unions. And that's really where I got my start, and that's where I fell in love with labor. Just great people, relationships are everything, you know that, Mike.
Yep.
So taking care of the members is most important, as we know. Making sure that the trustees know what's going on with their plan. It's always tough because they're doing a million things, and it's really my responsibility to make sure they're up to date on things and making sure that their members are taken care of. So I really like that. I got out of the space for a little bit. Then this opportunity at RxBenefits came up where they were looking to just have a unique labor team. Reached out to them. Quickly was brought on board to solidify the labor team here in the New York area.
Great. And where do you live now? Where are you living?
I'm in Queens. It's a little embarrassing moving from Brooklyn to Queens. I know that, but
it's all good.
So, usually you go Brooklyn, Staten Island, New Jersey.
Yeah.
I'm in Brooklyn, Queens, but it's okay.
And then Long Island, right?
Yeah, then Long Island.
All borderline. Everything's all borderline. All borderline.
Yeah, but I do love Brooklyn and Bay Ridge still very, very much. My kids are there actually still.
It's great.
Yeah.
And again, I know your passion for labor, your dedication. So it's really, exciting to see you with this particular team and then back in the mix again. So I know we had, we met about a month ago again.
Yeah.
And now to just see a progression in this particular role, I just wish you all the best. So excited for you.
Thank you. Appreciate it.
You got it. Faik,
Yeah.
tell us a little bit about yourself as well.
Yeah, so I'm been a pharmacist since 2014. Majority of my work was on the retail side. So I worked at a local CVS in Detroit. As you know, Detroit, Motor City, a lot of unions in that space, in that area. So spent 8 years there, pharmacy manager, working with, helping those union members at the counter, providing them vaccinations, assisting them with any questions they had, helping guide them to lower cost options, when the opportunity presented itself. I've been here at RxBenefits, had the opportunity to kind of shift, career paths and kind of get out of direct patient care. So been at RxBenefits for just over 3 years now. And, during that time, been able to work with funds kind of on the back end, looking at the pharmacy benefit side of things.
You work with the whole team, the account management team, just overseeing some of the clinical stuff?
Exactly. We have a strong partnership with the account management team, looking at our funds and their utilization trends, and kind of discussing different options that we might see. Just looking at data and things like that.
I was going to say data is everything, right?
Yes.
All the statistical information, how you create these efficiencies. It's all the numbers.
Absolutely. Yep. Data is clarity. Data is going to give you the ability to make better decisions. If you have that data and you're able to see your own data, that's one of the things that we bring to funds. Give them visibility in their own data, help them make sense of it, to provide the opportunity so they can make those decisions that are really based on that data. So they're not really guessing, when they're making decisions that are going to ultimately impact their members in the fund.
Yeah, in the union labor space, you're not dealing with one or two people. You're dealing with thousands of members. So
Yes.
when you look at statistical information and all the analytics that are there, some of the cost saving opportunities, or the fraud, waste, and abuse or spend, that information really is extremely relevant and makes when you're making those particular decisions.
Yep, absolutely.
So when we step into it, again, pharmacy is just so complex, and all the costs and things that are around. So it's such a critical piece within the healthcare spend. So to be able to have this information is critical. For the union leaders who may be hearing this for the first time, what is RxBenefits, and what role do you play in supporting union health funds and its members in detail? Your differentiating factor. Maybe you could step in there. Great.
Well, RxBenefits is not a PBM. It's actually a PBO, so it's a pharmacy benefit optimizer. It was started in 1995 in Birmingham, Alabama. And what it does, it works with benefit consultants, self-funded groups, and Taft-Hartley funds, and works not exclusively with them, but really with them to make sure that they actually help procure the PBM. They help make sure there's guarantees with the PBM, and they help make sure that you get that white glove service, that member service that you're looking for. In addition, RxBenefits has independent clinical management, meaning that the pharmacists aren't hired by the PBM. They're hired by us. And we take an independent look based on both the member and the fund's finances. Make sure that they're both being looked at, instead of a lot of times what happens at PBMs, unfortunately, is the pharmacist there is looking at the profits of the PBM and the member, as opposed to us looking at both the member and the trust fund. That's all we care about, because we're not a PBM. We're an optimizer. We're looking to optimize your PBM, whichever one you select.
That's yeah. So you come in as that essential consultant working on behalf of the fund, and then make those particular critical decisions.
Exactly. We help you with those decisions by providing you with extensive data, whether it be quarterly reviews, annual reviews, or just typically if we have a fund, we'll meet with them bi-weekly or monthly, go over any trends we see, any member concerns we may see, and we just dig into it, and we take a look and see what works for them. Maybe something's on their formulary that they think shouldn't be on their formulary, or something isn't on their formulary that they think should be on their formulary, and we have that discussion around, member access and fund expenditures. So it's a really detailed discussion. It's something that I know that probably all the trustees have had to have, but we're not on the PBM side.
Yep.
We're basically on the fund side.
On the funds. So you work with PBMs then, right?
Yes.
Right.
Right. We procured a contract for you through one of the big three PBMs, whether it be ESI, CVS, or Optum. And what you get with us is national account pricing. So because we have over 3 million members, we're really able to bring that pricing down. So once you pick the PBM you want, then we act as that person that uses our own clinical management to navigate the expenses of your fund, and also the member experience. So we don't use the clinical management of the actual PBM. We have independent clinical management, which is why we have him here to sort of let you know how that works, right, and why we think it's extremely important that there's an independent layer between the PBM and the fund, and that's us. Gotcha.
And Faiq, what problems do you see with traditional PBM incentives, and how does RxBenefits, the flat fee or transparency model, better align with union values today?
Yeah, so several problems exist, and some of that even comes down to the clinical management that we kind of already discussed. But looking at traditional PBM economics, where they're influenced by rebates. RxBenefits doesn't retain any rebates. We don't make decisions based on rebates. So what you'll have is oftentimes, a member's getting a medication that's more costly because of a rebate, and they're steered to a more costly medication. So those traditional economics, like you said, there is that inherent incentive that is going to lead to increased costs for both members and funds. And then, when you look at our approach, again, like we said, we have that independence, and really we sit on the side of the fund and the member with regards to clinical decisions. So ensuring members on medications that are safe, effective, and clinically appropriate, as well as affordable for those members. And, we work to direct them to lower cost options when we can. But when you think about you mentioned that transparent flat fee model, that's taking those incentives away from it. So getting away from trying to maximize rebates and discounts where there's, really a lack of clarity around, what a drug costs and what kind of decisions, why those decisions are being made, why a drug's on formulary, why it's, off formulary. We're simply looking to provide a great benefit at a good price and ensure that, members have access to quality care.
Gotcha. And another question for you, Faik, too, is we have, from a pharmacist perspective, what changes when clinical decisions are made by independent pharmacists like yourself instead of automated systems?
So a couple things. I think quality and outcomes. When you look at the automated systems, going back to that clinical management that's offered by the traditional PBMs, lack of oversight, and really it's, they're getting revenue from more expensive medications being filled. It's simple as that. They own specialty pharmacies. They retain rebates. At RxBenefits, our clinical approach, it's pharmacist-led, independent, and really the only focus is making sure members, again, are taking medications that are safe and effective for them, and that's it. And at the same time, looking at the fund, making sure those costly medications that aren't providing any additional clinical value, they're not going to be exposed to those types of medications.
Gotcha. Greg, being on the member side, can you break down how RxBenefits actually improves the member experience, cost savings, access, safety, and peace of mind? And I know, having a relationship, obviously, and a direct point of contact creates some of that member experience and just having somebody to, call, make sure that they're looking at everything. But maybe you can elaborate a little bit more on that.
Okay, well, first, most importantly, I think that our member services department is U.S.-based. When you call, you speak to someone. You don't sit there for hours talking to AI until somebody gets in front of you. As we know, stuff happens, whether it be at the pharmacy counter or somewhere else, and you may have to call customer service. And the last thing you want to do after you were just frustrated at the pharmacy counter is deal with 15 minutes of a chat bot or something like that. That doesn't happen at RxBenefits. We take our members very seriously. We provide that white glove service. And what that typically does is stop a call to the fund, right? If you take care of the member, great. If you don't take care of a member, now the fund is dealing with an irate member, and the member should be irate because they weren't taken care of. So first call resolution, but not on speed. We're not focused on speed. We're focused on accuracy and getting the issue taken care of. Unfortunately, a lot of guarantees are around speed of answer, and that doesn't really solve a problem. Is the member's issue being resolved by a human being in a timely manner that makes the member who was frustrated now get off the phone and be like, okay, well, they handled the issue. Because in life, there's always issues. If there wasn't issues, they'd have no need for us. Everything was perfect, right?
Right.
In the end. So that's the one side. That's the member side. And then we have the account side. Really where I come in as the strategic account executive with my account manager. We're partners. We meet every day to go over any issues or concerns, every single day for over an hour. And we'll go over any issues or concerns, anything that's escalated. And we typically talk to, fund managers or just every day. We're in contact with them. We build that relationship with them. When I was on the medical side, I had 10, 15, 20-year relationships with some of these people. Because the great thing about unions is a lot of times the people don't change, and you really could build that relationship with them. So that's what we're trying to do at RxBenefits. So it's member approach, fund approach, and then as far as overall cost, this is education, right? So how do we get educated members? What do we do? Whether it's webinars, teaching them how to use their portal, whether it's flyers, or however the fund thinks the best way, text, whatever they think the best way to reach their membership is. Having meetings, come in, have a town hall, which has been very successful in the past. Something that we highly encourage in this market because it's very complicated.
Yep.
We don't expect the members to know this. But, for example, what happens is, say a member goes to the pharmacy or they call specialty and have a specialty medication that might be $10,000. Our independent clinical team comes in and goes, well, you can get a biosimilar that's $1,500. Why don't you try it? Well, the member might get upset at that, not knowing that this is probably the way the market's going, and it makes sense not only for them but for the fund because the outcomes are similar or the same based on clinical trials over the years. So what we're trying to do here is make sure that the member gets the medication need, right medicine, right time, right cost, and the fund is paying the appropriate price. You don't want to just be overpaying for medication when there are alternatives that are much lower. So on the savings side, I see that education to the member being extremely important. There are so many drugs coming out in this space that are 85-90% lower than the original medication that are doing just as well. And we need to have that education so that as members move over, they're not upset about it.
Right. Right. And I guess you look at it, it lists all the different drugs that are there, or that 90% or 80% of the members are utilizing these particular drugs. Is there an alternative to that particular drug? And if it's 50% less, then all of a sudden you're coming in and you could drop or, create some efficiencies right off the bat with some of these pharmaceutical, drugs within a health plan.
Right.
Yep.
Well, in the end, you know that whenever you're negotiating, benefits, they don't want to change their copays. They don't want to change it. So the only way that doesn't happen is protecting the fund's bottom line. And there are a lot of unique ways to protect their bottom line so that when the next time negotiations come up, they don't have to go from a $20 copay to a $40 copay or, unfortunately, even to a deductible these days. So, that's what we're really looking to protect. We're looking to protect those benefits, allow the members to have the medication they need. And sometimes the medication they need is a lot less expensive than what they're being prescribed. And that's why we have independent clinical management.
Gotcha. Thanks, Greg, for that. That was great. Couple questions here. So what's the number one thing union members don't realize about their pharmacy benefits that could save them hundreds of dollars or improve their care? And it may go back to the biosimilars and things like that.
It's how much power they have. They have a lot of power. I don't want them to feel helpless at the pharmacy counter or when they go and get on the phone with a specialty rep that they don't have power. They have a lot of power. If they have to go back and get a PA or they're asked to change the medication, do the research, and that's where we're here to help. A lot of times that medication is as good, and in some cases better, for significantly less, and that's why you need independent clinical management. So not to repeat myself, but there's a lot of power they have, and I think it's important that they know that around their pharmacy benefits and what they can choose and the options that they have.
Well, just speaking to that, from my experience, again, working in the retail setting over 8 years, common misconception is the medication that's prescribed, they go to the counter, it's covered, there's a copay, members are going to assume that's the only option when it may in fact not be the most cost-effective option, and there might be something else that, like we're talking about, does the exact same thing for much less. I used to see it all the time. Somebody's paying a $50 copay for a brand name medication, and I knew there was a generic that was $5 copay, does the exact same thing. Over the course of a year, that $45 gap, it's over $500 that a member is going to be paying extra that they don't even need to. So, I'll give a real example. Medication, there's a medication called Xhance. It's an allergy nasal spray, same exact ingredient as Flonase, which you may know. It's an over-the-counter and a generic medication, does the exact same thing. The cost difference there, pretty substantial. So whenever I would see a member getting one of those medications at the counter, I'd let them know, you can take this much cheaper. They'd definitely be appreciative of. The problem is that the pharmacist isn't always going to have the opportunity to intervene. And then that member, like we said, there's misconception. They might assume this is the only option for them, or, they're not even aware to ask the question, or maybe they're reluctant in a busy pharmacy setting. So that's kind of where we come in at RxBenefits, we take that burden off the member. So we remove low clinical value medications from the formulary because we don't, we're not influenced by those rebates. So, the medication does the exact same thing as the higher cost medication, we don't want that member paying for that. So we're going to remove that higher cost medication off of formulary. And this is something that comes back to the fund too. It's going to benefit them as well. When you look at that same medication, Xhance, $600 a month to the fund versus less than $25. And, so when you look at that, fund's going to be able to save dollars to help provide, those same benefits to members like we talked about. So we're not having to increase copays year after year just due to wasteful spending. At the end of the day, we don't think members should be paying more for the exact same medication.
Question for you too, and again, this is just day to day. I'm a union member. I go to the doctor. They prescribe X amount of drugs. You check up. We're going to prescribe you to this, and this drug. Which pharmacy do you use? Oh,
Yep.
I go to CVS. I go to XYZ down the block,
Mm-hmm.
and they prescribe that drug, and they call it into the pharmacy. Where does that intervention come where they could determine, hey, we want to be able to lower this or provide that alternative drug versus X that the doctor may prescribe to intervene at that particular point
Yep.
to help reduce that expense for the fund as well as, just educating that member?
Yep. Well, there's a couple different points of intervention for us at RxBenefits. If it's a medication that's has a prior authorization attached to it, so like maybe a specialty medication, higher cost, we intervene at that point. And this is not anything that's going to lead to a delay in the prior authorization. But while we're reviewing that, we're reaching out to the doctor to educate them on some alternatives that may exist. We talked about biosimilars; those are starting to come at the forefront of specialty spend. Significant. You can think of them like generics, significant cost savings. Members, they are educated on generics. They've been around for a while now, but biosimilars are somewhat new. So we're providing that education to the prescribers as well as the members. And then in the example I kind of gave there, if a medication is something that we consider low clinical value, essentially what happens is at the point of service, that member is going to be made aware of it by the pharmacist at the counter. So like I touched on, the pharmacist can't always intervene, but when there is a rejection, they're going to intervene because they're going to be alerted to it. And then they're going to let the member know, here's something over the counter, or I'm going to reach out to your doctor and switch you to, what I know they should be on, essentially. So
I'd like to take a moment to thank RxBenefits for all their support of the ULA Network and the ULA Network's Charitable Foundation and believing in our mission to support, educate, and promote union labor in our communities. And you mentioned it before, or you brought it up. Is there a difference, or is it really one and the same when you talk about biosimilars or generics?
Yeah, so I like to think of biosimilars as, similar to generics, but the term similar is a generic is an exact copy, right? Mm-hmm. So a biosimilar, it's made of a biologic product, so it can't be an exact copy, but like a generic, it has to prove the same safety and effectiveness. So they have to do the clinical trials, make sure it works in the exact same way as the brand product, same dose, everything like that, have the same outcomes. So you can think of it like a generic. It's different approval pathways. It gets into kind of more logistical things there, and there's a little bit more complex laws with regards to it. But that's the way I like to think of it. A biosimilar is just a little more complicated generic, but essentially analogous to a generic. If you
Gotcha. And you think about it, it's like generic biosimilars, similar,
Yep.
And talk about it. It just goes a little bit deeper in regards to legalities and trademarks and things of that nature as well.
Mm-hmm.
Does the biosimilars, does that allow them to move a little bit more faster within the system? Generics may have copyright, so you can't do something.
Yep.
This Tylenol pill, it's on lockdown. Nobody's going to recreate the Tylenol or whatever the case may be.
Yep. No, that's a great question. with the term, is it getting to market sooner because it's not as stringent? Actually, it's probably the opposite. It's more stringent to launch a biosimilar than a generic.
Okay.
It's more costly, and there's more regulation around it. But a lot of it is really just administrative, and there's some talks. Actually, the FDA in the last couple months had said they're going to remove some of the stringent nature of bringing a biosimilar to the market within the next year here, and that could potentially accelerate, getting them more in line with how generics come to market. And from my experience, pharmacists, that's long overdue because there's been a lot of red tape that's kind of delayed it. And even in Europe, where we've seen biosimilars, there's widespread adoption, at a much higher rate than what we have, and they have the exact same outcomes. There's no safety concerns with regards to that. So a lot of it is just unnecessary red tape right now.
Right. Yeah. So I think that you think the United States over time is going to take a playbook out of like European, pharmacy spend or how they look at those particular costs.
Yeah. I mean, it's all about, reducing drug prices. It's huge. It's been huge for years. But these are real steps we can take when we know there's not a clinical difference and there's a substantial cost savings to a biosimilar. We want to make sure we can facilitate as quick adoption as possible. Humira is a perfect example. That came out as a biosimilar in 2023. Within a year, there was 1% adoption of that biosimilar product. The brand was still getting filled. PBM still wanted to hang on to that brand because of the rebates that the manufacturer would pay. So, funds members were not seeing that savings that the biosimilar could deliver. They're starting to get under more pressure now to try, as these biosimilars are coming out, they can't really delay it anymore. So it's starting to happen kind of more rapidly now. So over the next 5 years, there's going to be a wave of biosimilars coming through that can potentially positively impact, pharmacy benefits, downward as far as.
You might have just answered this one question too. I was going to say, over the next 5-10 years, where do you see the biggest opportunities to improve pharmacy benefits for you, especially around transparency?
Yep.
Talked about biosimilars. Everybody talks about GLP-1s right now, and models like Luminate RX.
Yes.
And maybe you could elaborate a little bit more about that.
Yeah, absolutely. So, in addition to biosimilars, transparency, that is another huge thing that's being talked about. Transparency or transparent PBMs, they're not new. They've been around for quite some time. But really, we're starting to see it gain traction. Last couple of years, we've seen states pass transparency laws. Some of the bigger players, the PBMs, have been forced to kind of change into that direction and offer some transparent options. So we're in agreement with transparency. We've been looking for a PBM to partner with that would align with our values as well as that of our funds and members. We couldn't really find anything in the market, so we created our own transparent PBM over the last year. It just launched in January. It's called Illuminate RX, and really it's getting away from maximizing rebates and discounts like I talked about and really focused on just the lowest net cost. So funds are going to have, clarity into how much they're actually spending on a prescription. They're not waiting on a rebate to try to, go back and look at how much are we spending, and try to project future spend. They're going to have more clarity, flexibility, and control over their plan as well with Luminate RX. So it's something that we're really excited about. It's an option that we're bringing to the table for our union funds.
I think we're trying to get out of the rebate game, which is really important. And it's important for funds because what a fund does is, say they get a medication in January and they have to pay $10,000 for it, but there's a $5,000 rebate associated with it. They'll get that back in July. Wouldn't it just be nice if they paid the $5,000 for a medication with no rebate?
Yeah.
So that's sort of what's going on, is that we're trying to improve, their cash flow with Illuminate RX through discounts, right? So what we want to do, it's like AWP, which is average wholesale price. What we're looking to do, instead of them paying, say, $1 million in average wholesale price up front and then getting money back in rebates, we're trying to drive that wholesale price that they originally paid down to, say, $700,000 or whatever it is, just through clinical programs, member education, formulary, all of these things that could really help them with the upfront costs. Even if you get it back on the back end, Why are you paying it up front?
Right.
What else in life do we buy in January and they give us half our money back in July? Right? When you go buy a car and it costs $40,000, you don't give them $80,000 and say, "Give me $40,000 back in July." You just give them the $40,000. So the real goal here is 100% transparency. What we pay for the drug, what you pay for the drug is the same.
Right.
There's no spread pricing, meaning that we're going to pay the pharmacy a different rate than we're giving you and things like that. We're going to pass through 100% of the cost and 100% of the rebates. And that's extremely important because it gives a lot of clarity to the fund to see what they're spending. But to me, when I look at it, the most important thing is upfront cost, right? The velocity of money, right? You want to make sure that you have this money and you can use it and you don't have to wait for it. Actually, at the fund level, it's really important. And I think for too many years, PBMs are chasing rebates, so that's nice when you get that big rebate check, but you paid all that money up front.
Absolutely.
What is that? What does that do? So they were holding your money for 6 months. Is that something you're happy about? I don't think it's something that you.
And when you're talking about
happy.
millions of dollars,
Yeah.
it's like the float, right?
Yeah.
You know, I'd love to have $5 million of float for a year, right?
Exactly.
You know, whatever interest you're able to get on, and
Right.
like you said, if it could be in the fund offices, you know,
Coffers, yeah.
coffers, it just goes that much further. And you know, when we talk about transparency and the technology, just people having a better understanding of how the money flows, I do believe there's going to be a massive paradigm shift with these biosimilars as well as these generics that could drive down the cost, as long as you can statistically show that these are, you know, very, if not identical, very similar, you know, to take this particular drugs.
I mean, yeah, generics did that. They did that, right? So 90% of the drugs probably prescribed today are generics. And the reason that they're prescribed is they're driving 85%, 90% savings off of the brand, right? Now it's time for biosimilars to do that, right? Whether it be Humira, which just came out with a biosimilar, Stelara just went into. Stelara is $140,000 a year, right? Now you have a biosimilar that probably is about 85% savings. Not 85% of the 140, 85% off of the 140. That's insane. So that when you talk about specialty, well, all of the funds and just any organization really driving at least 50, 60% of their spend for 2% of their membership, right? You have 2% of the membership driving 50 or 60% of the spend.
Yeah.
What can we do about that? Biosimilars. So as they come out, and these reference brands, which would be a Stelara or Humira or whatever it may be, Dupixent, that's probably a long way off that one from biosimilar. But my point is that you see commercials for these all the time. You don't see commercials for the biosimilars.
Right.
Right? So why is that? Those drugs, right? Humira was a $20 billion drug, right? I mean, that's the kind of revenue it's driving, right? Well, it has a biosimilar now, and that biosimilar is extremely inexpensive to the price of Humira. So drive members onto that medication, because that medication not only been proven, that's been proven in Europe for many years. I mean, as being extremely effective.
Yeah.
So as we get into that space in America, after we fight all the patent lawsuits and everything like that, which is really what the big issue is.
Absolutely.
You have to go through the legal process. I mean, you have to keep in mind they did invent these medications. They should have time, some type of time to get their money back on them. But at some point, these patent, they have to run out, and they keep going back, changing the formulation, extending the patent, changing the formula, extending the patent, changing the device that you use to changing the patent. So they keep getting extensions, and I think that's going to go away. And what will happen is they'll have their patent time, and then these biosimilars will quickly hit the market, and we'll be able to really drive down price. And the key there is member education, right? So what do? We got to make sure the members are comfortable switching from this drug that they've been on for several years to a biosimilar. And we have to do a good job of educating the member. Believe it or not, these biosimilars now, a lot of them can just be changed like a generic. Where if you go into the pharmacy with a brand name prescription that there's a generic for, the pharmacist can just give you the generic, right? Some of these biosimilars now, you can go in with a prescription for Humira and they can give you the biosimilar because they're interchangeable. That's how high a quality they are. So it's not like you're taking a stab in the dark. These medications are proven and they're working extremely well. So that's probably where I see specialty going, and then you're going to see a significant decrease in fund spend in this area. Hopefully more in line with, you only have 2 or 3% of members on these medications. We got to bring that spend down. right? Because it's 50, 60% of spend now. It becomes, unsustainable for the fund. So that's really where we're driving, looking to drive savings.
Yeah.
That has a lot to do, and is really important to me because that's the side I'm on. I'm not on clinical. I'm on the account management side. It's driving that member experience, helping this member understand why this is happening, why it's important to happen, and really driving that white glove service on the member side. Because if they understand and it's working for them, they're happy about it. If you just do it to them and don't let them know why you're doing it or what the rationale, they're going to be pissed off.
Yeah.
I mean, I would be.
No, I understand. And listen, it's a lot of money movement.
Mm-hmm.
So that, I mean, again, you're cutting off different food chains when you're taking something down from 20 billion to like, a couple $100 million. Like there's where does that money go? And then, people's lives and different, legal law firms, other institutions that have been feeding off that one particular pill, to be able to reduce that and then create.
Oh, they're ahead of the game. Don't worry.
efficiencies.
They come out with new agents. they come out with new
additional
agents.
drugs.
They're going to have to become, that's going to take them another 10 years to make a biosimilar for it. So they're really smart pharma. They knew this was coming, right? Because I think in 2016 this biosimilar came out, and they had a patent to 2023, and that's when as you mentioned, that's when it came out. So they have a 7-8 year window on this to know to come out with, and they always have pipelines of really strong specialty medication, because that's where the money is.
Yeah. No, this is the biggest spend in most healthcare spend today, right? It's in the pharma.
Yeah.
Well, I mean, medical's always
Medical.
more, but the biggest trends have been in specialty medication, right? Because there's so many more people that diagnose, whether it be Crohn's disease or some type of some type of inflammatory condition, and you need these anti-inflammatories really to attack them. And the problem with specialty medication is they're really good and they really work, right? So when members go on it, a lot of times they're on it for life. And even in fact, some of these cancer medications that used to be acute, remember, will go on it for 12 months, whatever. They're on it for 5 years now, 6 years, because they're working as a maintenance medication.
Yeah.
And you have extreme spend there. So this is the kind of thing that we really have to make sure that we watch closely as a PBO, and make sure that, listen, if a member needs the medication and it's really expensive, they're going to get the medication, as long as it's the right medication. That's not what we're talking about here, but we're talking about making smart decisions in this space. If there's something in that space that makes sense, that does the same or similar job as the medication that they're currently on, let's talk about moving.
Yeah.
Yeah, I mean, just to kind of touch on it one more time and kind of what he's getting to, the manufacturers know biosimilars were coming about. Humira, the makers of Humira is AbbVie. They also make Rinvoq and Skyrizi. So you may have seen commercials on TV for those. They're really aggressive on the direct-to-consumer front, as well as the prescriber detailing, to actively switch those members who they know are on Humira and they're about to switch over to a biosimilar. Let's get you on this new product that still has its patent. And so it's not about getting members to switch to medication that's less effective, but if they're already effective, having a good effect on that Humira and just getting switched to biosimilar, we don't want a manufacturer to unnecessarily keep them on that high cost medication. It's going to ultimately impact, the fund's bottom line as well. So,
Gotcha. Anything for you, Greg? Anything?
No, that's it.
That's it? That's it?
Yeah. On this subject, yeah.
I got you. Well, again, for union leaders listening now and today, what's the first step they should take if they wanted to understand whether RxBenefits could be the right fit for their fund?
Well, the first step you would take is to reach out, right? And then what we could do is a claims analysis. Take a look at the fund's claims, run it up against our contracts, and what we think we could do on the clinical management side, which would really be the key difference. We will put our program in there. It's called Protect, and see how much savings that would drive with that independent clinical management. And then we come back to you and see whether it works or not. If it doesn't work, great. That's okay. We could try again next year or the year after. But if it works, and then we would just go into the next step, have a conversation, and move forward in the process around it, if we wanted to move forward, or have more conversations with trustees and or the members. In the end, that's what it's about. This is, as you know, Mike, we've been doing this for a long time. Member driven. We need happy members. We need really happy members. We need outstanding customer service, and that's what we're looking to do. But still, always the price has to be right, as you know. Right.
Yep. And when you talk about that claims analysis, is it always easy to get that information? I mean, sometimes do the fund offices have that readily available to provide you, or do they really have to go back to a PBM that may have that data and analytics? I know that there has always been some issues too. Nobody wants to release that data, right? I mean, that is so critical and gives the lifeblood or understanding of like where all those particular spends are.
Yeah, if they have a benefit consultant that's working closely with them, some of the larger funds do. The PBMs are all releasing probably to the benefit consultant monthly reports, claims data, things like that, and that's certainly good enough for us to run a claims analysis on. If they don't have a benefit consultant, then they would probably have to reach out to the PBM directly for the information, but it should be available to them because they are self-funded. If you're self-funded, it's available. Don't let them lie to you, right? You're self-funded. The information for you to have a claims analysis done is available to you. No one can tell you it isn't. And I don't think they would either, but they might not give you every single piece of data, but we don't need every single piece of data. We only need about 5 or 6 pieces of data really to run it. We get more and more precise as we get more detail.
Yeah, of course. You can start to refine that a lot more. I mean, but you typically just jump into like the most expensive drugs that are weighing on the fund, I guess the biggest piece, and then start to go down the pipe. Right.
Yeah, I mean, it sort of jumps off the page at you, what's going on. Is the specialty management program being run right? Is there that clinical vigor that we need? How are they doing on the GLP-1s, which we know is another huge spend? Do they have weight loss coverage? Don't they have weight loss coverage? If they do have weight loss coverage, is there a PA around it? Is there a weight loss program around it? That's all stuff that you find out a little bit later, but all really, really important information because that's really where the spend's coming from. Specialty and these wonderful drugs we call GLP-1s, whether it be Zepbound, Wegovy, Saxenda, Ozempic, whatever it is. There's tremendous spend around them. I know the funds are really concerned about it, and we do an outstanding job making sure, not denying people, but making sure that they have to be diabetic to be on a diabetic GLP-1. If they're not, they're going to get denied, right? And then they can't go on a weight loss medication unless they qualify. When or some funds now, because it's been so expensive, actually have eliminated these GLP-1s from weight loss. And, it's unfortunate, but in the end, the fund has to survive, right? And you have so much spend in that area that, what we do there is we actually offer a weight loss program. So it would be something that we offer to the members to join. And it would be obviously member paid if they went on any medication like that, but it gives them the support they need to go through that journey.
Is there the generics for GLP-1s? I know you went through a few lists of different organizations or similars that are out there in this particular weight loss space.
So right now there's just one, but it's less frequently utilized. So Victoza was one of the first GLP-1s for diabetes. It's once daily. It doesn't have the same weight loss effect as your Ozempics, Wegovy, Zepbounds. So that's unlikely to see, much utilization for weight loss. And even for diabetes, they're starting to shift to those once weekly agents that are more effective. There is going to be a once weekly, I want to say, within the next year, Trulicity, that's more effective than the Victoza that has a biosimilar coming out for it. But some of these other big players that you're hearing and you see the commercials for, it's going to be a long while. One significant impact that around these GLP-1s from the Inflation Reduction Act, Ozempic, the ingredient semaglutide, it's Ozempic and Wegovy and Rybelsus. It was selected for negotiations as part of that for Medicare Part D spending, which will go into effect in 2027. So that can potentially, we know it'll reduce spend in the Medicare market next year. See if that's gonna flow over to the commercial side of things. That's gonna be one to watch and something we're gonna be monitoring.
Gotcha. Mm-hmm. Guys, a lot of information you guys share with us today too. I mean, It's really cool things and incredible stuff that you guys do in RxBenefits. And again, the transparency, I think, today with the data and the information to drive down these costs, it's all coming down the pipeline right now.
Yeah.
And like you said, education is so critical. I mean, again, for us today with ULA Network in general, it's just to educate people about what these benefits are all about, what you get as a union member, and as well as the career opportunities and, from public sector to building trades, like what programs and products are available to you, and make sure that they're taking advantage and utilizing those services.
Yeah.
So we're in line with regards to, from an educational standpoint, we're proud to work alongside you and have you as a sponsor, really supporting these opportunities to educate members on the benefits that they have, their health and well-being. And again, pharma plays such a critical role in the overall picture of like wellness in today's marketplace. So just want to thank you guys both for the time.
Absolutely.
Awesome time. Thank you.
Yeah,
I
no,
appreciate
great.
it.
So, I mean, again, and before we round up, I mean, we should just kick it back a little bit more. I mean, that was so much information, my head's going to pop. But, Greg, again, what do you like to do on your personal time? And I know what you got, from a pool standpoint. I know you're like, in the pool space. You're like a rock star. So people should be looking at you, learn a little bit more about this guy that's,
highly competitive pool player. I like to travel and play in professional pool tournaments around the country. And I do well. I mean, considering I'm a guy who works 5 days a week and doesn't get to practice as much as I like, I do well. I've had some really, really good experiences in pool. Even way back, I guess in 2016, it was a reality show called The Hustlers, which I starred in, and I had a great time doing it. And I know you know that.
Yes, The Hustlers.
It was really fun, super interesting being actually on TV. So you're sort of mic'd up 60 hours a week. And what's interesting about that is then they make a 40-minute show, and they can take any clip they want of you, the good, the bad, the ugly. With me, unfortunately, they took all the bad. and I became the overbearing husband, unfortunately.
Oh, my God.
But there's a lot of pool in it, and it was so much fun. And I would have loved to keep doing it. But unfortunately, just like everything else, things go away in life, and new opportunities come.
No, again, that's a passion that you have too. I mean, again, I love playing golf. You love playing pool. Mm-hmm. Any things that you like doing in your spare time, Mike?
Yeah. Well, first, what channel is that on, or what station? I got to check that out.
Yeah, if you didn't know that, did you even know about this?
It was on TV, but now it's on Amazon Prime.
All right, I'll check
Amazon Prime, and what is it? The Hustlers?
The Hustlers, yeah.
The Hustlers?
Yeah.
Hustlers, Amazon Prime. Check it out. You can see Greg McAndrews on there.
So
your account manager with RxBenefits.
For me, not that it is exciting as that, but like to be active, lift weights, play sports, pick up basketball a lot, try to stay moving. Golf's another good one. I'm terrible at golf, but I like to hang around with the boys and kind of do that type of thing. So that's about it.
And have you always lived in Detroit? Always been in Detroit?
Yeah, for the most part. I was down in Tampa for a little while, but Detroit's pretty much home. So.
Gotcha.
Yeah.
Kids, family?
No kids, niece, nephew. Could spoil them. So.
Yeah, no kids. I'm the godfather to my niece.
Yeah.
Yep.
How about yourself, Greg?
I got 3 kids, and as I told you today. My son's first day with the Department of Sanitation today. Extremely excited. I'm so happy for him. He's got a big smile from ear to ear. Actually, he got to start early this weekend because of the snow, so he got a little overtime to start off.
As soon as he gets started, he gets overtime. Yeah. Incredible.
Yeah. So really excited about that. My dad was a fireman, so really believe in the city unions and the great jobs that they offer. So I'm so excited that he's doing that now.
Yeah, I mean, again, like we talked about, Greg, growing up in Brooklyn, I mean, from cops, court, firemen, police officers, the different trades that we've dealt with, just growing up in our neighborhoods. Mm-hmm. We know what these career opportunities really look like. Mm-hmm. And then fast forward, we look at our professions and growing in, and how do we play a role in supporting those particular members that really keep the economy and communities going. Yeah. Mm-hmm. So as we can help educate them on useful spend, work with the funds to drive down those costs for better benefits, to diversify, the whole well-being, is really important to me. And we have such great networks. It's like, how do we utilize them for good, and really support the union labor organizations that drive real economic, good careers, and these unions are the ones that are working with you to negotiate these better pricing and benefits for their livelihood. So, again, we're all in this one mega ecosystem, and to have some really qualified people that have been doing this stuff and really dedicated is exciting. And, again, we have a platform to, highlight that. And I'm just so excited to have you guys here today and, again, sharing your experience, your life, and your dedication to union labor. So I just, again, want to thank you for that.
Yeah, well, thanks for having us.
Yeah, no, absolutely, man. Absolutely. So as we scripted our outro right now, this is exactly why conversations like this matter. Pharmacy benefits are complex, but they don't have to be confusing, misaligned, or unfair to union members. Huge thanks to Faik, to Greg from RxBenefits for their commitment to transparency, clinical integrity, and pro-union values. And to our listeners out there, if you're a trustee, fund administrator, or union leader, stay informed, ask questions, and work with partners who truly sit on the side of the member. We'll see you next time on the Union Labor Advisory Network. We want to thank you for all you do. What we're going to say. Follow, like, and subscribe. Check us out.
Love it.
Again,
Follow,
we
like,
appreciate
and subscribe.
all that you do, and we're proud to support our union labor family. So thank you. I'd like to thank all our sponsors for helping to build and promote the ULA network. It is because of you that we're able to support, educate, and promote informative content relevant to labor. Please subscribe, like, and share our channel and media. I'd like to thank you all for your support.